Good afternoon. Welcome, everyone. Glad to see you. We are just at 3 o'clock and we see more participants rolling in. We'll give it a few moments to let everybody get settled, and then we will get started with our webinar. In the meantime, if you would like to introduce yourself in the chat, tell us who you are, if you represent an organization, and in what part of the country or world you're in. That would be wonderful. Well, folks, we've got quite a few of you here, so we're really thrilled to have you, and we're going to take it away. So my name's Elisha Coffey. I'm the Vice President of States Advocacy with Mental Health America. We're thrilled that you could join us for the Regional Policy Council webinar, Building and Paying for a Stronger Mental Health Workforce. This hour-long webinar will feature national experts exploring challenges and opportunities to developing and sustaining that mental health workforce. Our format today will include 3 presentations. Each presenter will have the opportunity to answer your questions at the end of that presentation. So please put those questions in the chat and we'll have them answered as time allowed. So you know, we will share PowerPoints and speaker contact information as permitted in a follow-up email in the next few days. Now, before we get started, I want to share a little bit of gratitude. I want to thank the Regional Policy Council sponsors and funders who make this work possible. We receive generous support from Bristol Myers Squibb, Compass, Johnson & Johnson, Pfizer, Myriad Genetics, Neurocrine Biosciences, Otsuka, Sage Therapeutics, Biogen, Takeda Lundbeck, and Teva. So thanks to them, we're able to make presentations like this possible. I also want to thank Shanna Mulvihill, one of 4 Regional Policy Council lead representatives who suggested this subject and connected us with our first speakers. So I'm very pleased to introduce you to Melissa Serafin, research scientist at the Amherst H. Wilder Foundation. Melissa specializes in mental health, substance use, well-being, suicide prevention, and community safety. She's particularly interested in expanding access to mental health care, reducing mental health stigma, and strengthening and diversifying the mental health workforce. Joining her is Dr. Roy Kamer, Interim Associate Dean of the College of Allied Health and Nursing at Minnesota State University. Dr. Roy Kamer holds an appointment as an associate professor in the Department of Health Sciences. He is a long-term member of the Minnesota State Epidemiological Work Group, and he specializes in topics related to behavioral health workforce, credentialing, ethics and professionalism, and alcohol and drug policy in higher education. So as you can hear, we have some pretty impressive experts in the room, and we're just getting started. So please, Melissa and Roy, take it away.
Well, good afternoon, everyone. So happy to be here. Again, I'm Roy Kammer. I'm here with Melissa today. I just have to give a quick call out to our other researchers who were a part of this project. Mia, Carrie, Morgan. It took a lot of people to make this happen. So we're just really excited to talk about the work, and I'm going to jump right in. And I've jumped a little too far. So let me start out and just tell you just a real quick background about this study. We all know there's a really severe shortage of mental health providers, not just in Minnesota, but all around. I can tell you in Minnesota, vast majority of our counties are a mental health service shortage area. We don't have enough providers. I imagine that story holds true for many, many, many people on this call today. So part of what we were curious about is, how do we make that better? How do we increase providers? One of the indicators that we look at is the licensure process. How many people are licensed? How many people are pursuing licensure? And one of the things we discovered here in Minnesota is that over 50% of the people who get a master's degree in behavioral health, whether it be counseling, marriage, family therapy, social work, they don't go on and get a license. So that's kind of why we titled the study the way that we did, Unfinished Business. We have a lot of people investing a lot of time, a lot of effort, a lot of resources into getting a graduate degree, and they don't go on and get a license. And we were curious to learn a whole lot more about why that was. We wanted to figure out what are the barriers and how can we remedy those barriers. So let me just tell you a little bit about how we did the study. In Minnesota, we have 31 different programs that offer a graduate degree in social work, counseling, or marriage and family therapy. We reached out to all of them. About half of them opted into the study saying, yeah, we want to participate. We are going to send this out, recruit graduates from our programs to give you information. All said and done, we had quite a few responses, but after we cleaned those responses, we had about 144 valid survey responses. And in that survey, participants had a chance to opt in, telling us if they would be willing to participate in an in-person interview, a live interview, I should say, to get more information. So we actually had 41 interviews. So when you combine the survey data with really the qualitative data that we got from having these stories, hearing these voices, it really helps us to understand a good idea of why we have these barriers, what these barriers look like, and we're going to talk about some of the recommendations that came out of this study. So you'll get a link to the full study. We're really going to hone in on the recommendations. I always like to tell people, as we go through this, I imagine a lot of this will resonate with what you already know. So I think this really helps to validate some of those suspicions we might have, and just keep moving here. So the first recommendation that comes out of our study is really this need to continue to look at ways to reduce costs associated with becoming a mental health provider, um, including how we might increase wages and provide more financial assistance. As we did the research, we really saw a lot of different themes emerge in this area. One is there are a lot of different costs. So when you think about people participating or practicing as mental health practitioners, there's everything from licensure, there's background studies, there's all these upfront costs that come very early on. In addition to that, we heard a number of participants tell us about low pay, low reimbursement rates, periods of unpaid labor, or items they might do on a regular basis that aren't associated with pay. Now, we could spend a lot of time telling you about, the specific voices we heard. I've just got a few highlighted here, and we have these in each of our different recommendations. But these were the types of stories we were hearing from participants who participated in the interviews, just talking about all the money they have to pay throughout their careers and all sorts of different fees. The fact that there's supervision that's required. And granted, some people might get supervision as a perk of where they work, but a lot of people are paying a lot of money for supervision. You start thinking about continuing education, exams, study materials. Uh, add this into the fact that counselors, mental health practitioners, social workers don't always get paid a lot of money, right? So people are saying we could actually go and even after this master's degree, go work somewhere else in a different profession for more money. One person said, I used to work in a nursing home. I could go back and make more money there, even with this degree that I've earned. And then ultimately, in the mental health world, there's a lot of uncontrolled variables. We can't control when clients do or don't always show up. We can do our best to increase that engagement, but there's times when that goes unreimbursed, and that can have a huge impact, particularly for someone who's new and getting into the field. So recommendations. In this particular area, there's a few things we recommend. And I'll tell you here, the general layout, if you take a look at our full report, is we've tried to categorize this by what are things licensing boards and other regulatory boards can do, what can payers do, what can employers do, and what can educational programs, graduate programs do. Well, something we heard from our participants was, could you reduce the cost of licensure? It gets expensive. Could you eliminate that cost? Could you provide more assistance? That's something we've got to continue to advocate for. Is there a way you can reduce the cost of tuition, provide more support? People said, loan forgiveness is great. And are there more opportunities? Are there opportunities that are less restrictive to allow more people to get loan forgiveness to help them out? Can we provide free licensure exam preparations? If you ever purchased an exam prep guide, they get really pricey, right? So are there ways we can help people get into the field much more efficiently? And can we streamline things so professionals are spending less time on documentation and other things where there might not be payer reimbursement to really try to help things balance out? Because when you merge together high cost and low income, it's just a really tough situation. It creates a barrier. I want to move on. Second recommendation that comes out of the study is really related to the licensure application process and the support that goes along with it. Some of the themes we heard here is that this process can be really lengthy, burdensome, confusing. We heard a number of people, and this ranged across 3 different licensing boards in our state, really say that, we wish there was more communication. We get people are trying hard, but we need even more help. We need more assistance. Our state requires a background check process and fingerprinting, which adds another layer of complexity. And then they said, we don't always get the communication we need from our graduate programs. And sometimes we hear different things from our graduate program than the licensing board, and that makes it extra confusing. We heard a lot of concerns about the exam processes and how that adds, again, additional complexity to the whole process. Um, so what does this sound like from the participant voices again? These are individuals who have earned a master's degree. As this first individual says, I'm a good reader, I'm a good writer, English is my first language, and yet this application, it made me cry, right? So we have really, really quality people who are struggling through an application. So we've got a disconnect there. We have people saying, I go through these programs, and yet they're asking me for all this minute sort of information in the application. Is it really all used? It feels like busy work. We have applicants telling us that, these websites, there's a lot there, but it's a lot to take in. And a lot of it sounds like legal jargon, right? It's words, phrases that are not always easy to understand. And then you have issues such as applying for licensure. And on top of that, oh, you have to take an exam. And that exam might have a whole separate application process to it. That becomes inundating. So what are the recommendations here? Well, we really encourage boards, regulatory agencies. We have to take a look at how we can streamline things. We often hear it's been done this way or it's done this way. Well, how do we move the dial there? How do we say, are there other ways it can be done better? Do we really need to collect this information? Um, a lot of people said, are there ways to create online portals or change up processes so we can see in real time what we've done, what we're missing? Can we simplify the background study process to make it more integrated? other aspects here, like looking at how responsive boards are. Can we track, can we find some way to ensure boards are getting back and giving the information that's needed to really help people through what feels like a cumbersome process? And then like graduate programs, for instance, there's a wide range. Some programs do a really good job. Other programs may not provide the same level of information. How do we level the playing field to ensure everyone's getting the information and support they need, not only to get through the graduate program, but also to make it through the licensure process? Third recommendation that comes out of a report is this whole idea of flexibility of licensure requirements. And really what we're talking about here is there's a lot of strict requirements all the way from the types and number of hours that need to be accumulated to how the timeline for those hours. And then supervision, who can supervise you? And there's differences across the boards. And then just generally obtaining the hours in general. So things we heard in the participant voices, just to give you a sampling here again, is that when you're treating people with mental illnesses, and they've worked through a program, and yet on top of that, they're asked to do all these very specific things, a certain number of hours here, a certain number of hours there. That's burdensome. That feels overwhelming, and it takes away from the time that they might be able to just focus on seeing clients, helping people get better. Um, Also talked again about timelines, saying, I work hard. I've got to work hard to pay for these bills, to pay for these expenses that we talked about earlier on. And I got to get supervision. And it is hard to balance it all. It's hard to have good self-care when you're doing all of these pieces. And then again, people said, I got to accumulate these hours, but yet being brand new in the field, not everyone wants to see the brand new person in the field. And yet I'm told I need hours in certain areas, and that's a barrier. So in general, the recommendation here is we got to identify ways to be much more flexible in these requirements. What needs to be there to protect the public, but what can be flexed? The final recommendation I'm going to talk about before turning it over to my colleague Melissa is this whole idea of how we really align licensure types and state portability. What we have heard consistently from our participants in the study is that there needs to be more consistency from license type to license type, and hopefully from state to state. Now, we know there's a whole lot of work going on in terms of compacts and so forth. But in general, how do we do a better job overall with portability and making it easier to help people, no matter what license you have or no matter where you might be practicing? Uh, so the voices again, and really want to focus on the voices here because this is really what helped, guide the recommendations. But, one person says, how can we have more consistency across all these different licenses? There's incoherence, even though we're essentially all being trained to do the same kinds of work. We have people calling out, could we have a more nationalized process, a nationalized licensure process that makes things more redundant, because it doesn't feel redundant right now? How can we make it easier to practice? We have a large metro area in Minnesota that's very close to Wisconsin, for instance. So we have a lot of people who practice back and forth from state to state. And again, doing very similar types of work, but how it's done and the requirements can feel very different, which is an overwhelming barrier for people trying to get into this field. Um, Also, just I think the pandemic, if nothing else, did a good job illustrating for us the importance of being able to be flexible and where people are at. You have some states that say you have to be here and they have to be here, have certain location, geographic requirements for practice. Other states do not. It can feel overwhelming to manage all of those differences. So recommendations that came from the voices we heard throughout the study, sorry, fast forwarded there, is that we need to increase that alignment. And we also need to consider how we not only align things from license type to license type, but from state to state. And Melissa, I'm going to go ahead and turn it over to you.
Thank you, Roy. All right, so our next recommendation is around supervision, and specifically helping graduates find supervisors and then also ensuring that supervisors are providing quality supervision. So respondents talked about how it's really difficult and time consuming to find information about potential supervisors, their availability, the specializations, populations they work with. And the second kind of theme we heard was that there are some employers, of course, that assign a supervisor, which circumvents the need to find and pay for supervision, but then it also means that they might be given a supervisor kind of randomly that might not align with their goals, and it might introduce some role conflict as well if they're also serving as their kind of work supervisor. And then folks also talked about quality concerns. They talked about how some supervisors were not completing paperwork on time, providing incorrect information, being unfamiliar with their responsibilities, canceling or ending sessions earlier than they should, and even demonstrating inappropriate or discriminatory behavior. And so you can see those themes in these quotes. So the first person is talking about how they can go online and find supervisors, but they really have no idea if what the person is saying is actually true. Like, are they legitimate? Have they been approved? So just trying to navigate that process of finding an approved supervisor. The second quote is from someone in a rural area talking about their limited options, and like Roy was referring to, kind of that telehealth piece and how important that opportunity or that option is for supervision specifically. And then the last two are regarding quality, with frequent cancellations negatively impacting this person's supervision hours and actually their ability to meet licensure requirements. And then the last person talking about poor boundaries that they have experienced with supervisors. And so our recommendations here are around creating a directory or database with up-to-date information and detailed information about supervisors that could be managed by boards or regulatory agencies that would be able to ensure legitimacy. Looking at and addressing equity issues within the supervision process, I'll return to that in a bit too. Providing guidance about the process of assessing a supervisor and their quality, their alignment with the graduate's goals, and then looking at ways to increase oversight and accountability to address those quality concerns. Our next recommendation is looking at licensure exams. And I know Roy kind of touched on this earlier, and just kind of supporting students more with that process. So respondents in the study talked about how difficult the exam is, that graduate school did not necessarily adequately prepare them for the exam, and how more preparation support would be helpful. So things like study guides, study sessions, things like that. They also talked about how they felt like the exam is not really an effective measure of their competency or their clinical skills, and rather that it just kind of felt like they were checking a box, and that studying really only benefited them through learning how to take the test rather than improving their skills in any way. Some folks talked about how the correct response, quote unquote, does not necessarily align with how services operate in real life. And then they also talked about how standardized tests are inherently biased, and that it is often more difficult for folks from marginalized backgrounds to pass them, particularly those who are not fluent in English. There were some themes too around problematic wording, confusing wording, unnecessarily complicated statutory languages. So some quotes here. The first person is talking about finding quality study materials and how the material that they ended up using actually had no alignment with the national exam, which was really confusing for them. The second person is talking about how they got advice about how they should respond to exam items, but it's not really how you should respond to something in real life. And it just made it feel like the goal was to memorize information rather than assessing clinical skills. The third quote is similar, talking about how the structure of the items is more confusing than it really needs to be. So our recommendations around this challenge is providing more resources and supports to help graduates pass exams, even identifying alternative options for graduates to demonstrate skills and competency. And some actually recommended removing the test requirement altogether if it is just a box that folks need to check. And then making sure the content is more aligned with assessing clinical skills, and that it's written and structured in a way that kind of minimizes bias. And then, of course, just making sure that graduates can take the exam in languages other than English, and ensuring those translations are high quality. And then our next recommendation is around diversity, equity, and inclusion issues and supporting providers who come from marginalized backgrounds. We all know that there's a lack of providers from diverse backgrounds, and that most providers are, straight white women. So respondents definitely echoed that theme. They talked about how all of the other challenges we've discussed are more acute for folks from marginalized backgrounds. Respondents talked about the explicit and implicit discrimination they experienced within the field and throughout the licensure process. Some specifically mentioned the lack of diversity among supervisors too, and how this negatively impacts providers who specifically want a supervisor that shares a certain identity with them. So the first quote is talking about how all the barriers we've discussed are particularly problematic for folks from these backgrounds. We don't have enough diverse providers, but we make it too hard for those folks to get through the process. And the second is talking about how their identities made navigating the process more difficult, how they did not feel respected or understood in their work environments. The third is talking about how they haven't been able to find a supervisor with a shared identity and how that's negatively impacting their development as a provider. And the last is talking about a similar idea, but also saying that folks from these backgrounds carry an additional burden that might impact their ability to even be able to provide supervision. So our recommendations regarding this theme really relate to all of the other recommendations, since they all impact diversity and equity, really just making things easier, streamlining things where we can, but then also looking at resources and supports that could help folks from marginalized backgrounds better navigate this process and just get through it. So funding opportunities, tailored help to finding supervisors, things like that, and then back to exam content as well, just making sure those equity issues are addressed. And then lastly, work well-being and administrative burden came up a lot, which is probably surprising. Respondents shared that provider well-being is generally not a priority, high workload and caseload expectations, a lack of benefits that come with contract positions, the high level of administrative and paperwork documentation, and the bureaucracy that providers need to navigate, most of which is unpaid time, like Roy was referring to earlier. I want to specifically mention the credentialing process, as that was an issue that many respondents identified as extremely burdensome after getting through licensure. And then, of course, compassion, fatigue, and secondary trauma. So this first person is talking about how all the self-care messaging in the mental health field often feels performative, and how low pay negatively impacts well-being. They're like, well, here's a pizza party, and what they really need is higher pay. The second person is talking about high caseload expectations. And then the third is talking about paperwork expectations and how they feel like the paperwork could probably be streamlined. And then again, the credentialing process, how licensure should be sufficient to prove the eligibility for credentialing after all of the other steps you already needed to go through. And then lastly, the emotional intensity of being a provider and how it can be difficult to prioritize your own well-being in this field. So our recommendations here are around making sure wages are livable, providing benefits, providing other well-being resources, anything that you can do to support the well-being of providers, streamlining and minimizing documentation and other administrative tasks as much as possible, like Roy was mentioning earlier. And then, of course, just making sure that caseload expectations are reasonable. And I think that's it. So I know that's a lot. There's a lot of information in our report too. So we really encourage folks to read the full thing. But and I think there's some questions in the chat, but we appreciate your time.
Melissa, thank you so much. And Roy, thank you to you as well. We really appreciate you both being here. And yes, we do have a question in the chat. It's I know you're talking to advocates. And so the question in the chat from Hilda Tomeo is how can associations assist in this process? Are there working groups, or are there social work organizing associations that might be ready and willing to take this on as an advocacy issue?
Yeah, I think associations could play a really significant role in advocating for legislative changes, but also how big health systems operate. Really, just being able to emphasize and kind of have, like Roy was saying, like just having the data that now that we have to show that these are really significant barriers. So I think that advocacy piece is really critical, both legislatively and then also kind of lowercase p policy as well in small organizations.
Yeah, thank you very much.
Yeah.
Thank you. So folks, if you have more questions for Roy and Melissa, please put them in the chat, because if we have time at the end, we'll be able to revisit that. I also want to let you know right now, I just popped into the chat the link so you can see the paper that they produced based on this research. So now we're going to shift to Dr. Mark Salzer, who is the Principal Investigator and Director at the Temple University Collaborative on Community Inclusion. And Dr. Salzer has been the principal or co-principal investigator on more than 3 million in federally funded research grants. He's published more than 150 articles and book chapters on the delivery of effective community mental health and rehabilitation services to individuals with psychiatric disabilities. So Mark, please take it away.
So 37 years ago, I started my doctoral training in clinical psychology. And as part of that training, early on, I was learning about psychiatric diagnoses and impairments and symptoms and brain disorders and serotonin and dopamine going out of whack and enlarged brain ventricles and all the symptoms associated with all these things, as well as the types of interventions that traditional clinical psychologists are involved with. At the same time, I had an opportunity to work with a self-help mutual aid group for people with significant mental health issues that had actually started in Australia in the 1950s and came to the United States in the late 1970s in order to kind of get a foothold here and expand the work that they do. This particular organization was called GROW. My job was to actually support this organization, the Self-Help Mutual Aid Organization, in any way I could. As part of that process, I was able to sit in on GROW group meetings. And as part of doing that, or while doing that, going to meetings from this 12-step oriented group at churches, community centers, libraries, I saw people with lived experience doing things, supporting one another in ways that I knew I would not be offering as a non-peer professional. And I thought this was amazing. This has been something that has stuck with me for a long time, and I've been quite fortunate to be able to do research in this area for a long time. We've known about workforce shortages in mental health for 60, 70, 80 years. There's been a lot of discussion of this for a long, long time. About 50 years ago, there was somebody named Frank Reisman who really does amazing work and did amazing work in a lot of different areas. And Frank Reisman talked about the importance of valuing and including what he referred to as paraprofessionals in lots of different settings, in education, but also in healthcare. And he talked about something called indigenous paraprofessionals, and he referred to these as people without formal, what we would now say kind of professional education, but they are from the community they serve, and they provide supports to one another that is beneficial to one another. So this is the idea of paraprofessionals. At the same time, there was somebody named Alvin Toffler, who wrote a book, The Third Wave, and he coined the term prosumer. The idea of a prosumer is somebody who not only receives services, but also delivers or offers services as well. And he talked about self-help groups as one example of prosumer activities as a way to benefit other people. And of course, there's somebody who I was able to get to know a little bit named Judy Chamberlain, who wrote a book in 1978 that was really seminal called On Our Own. And Judy really advocated for patient-controlled alternatives to traditional mental health services. It's an amazing book, and I would encourage you all to take a look at it. So this really set off a long-term interest of mine in peer support services. And I've been very fortunate over the years to see peer support services change over time, including becoming more professionalized and being eligible for Medicaid reimbursed services. For many, many, many years, these types of programs, if they received any government support at all, they would receive it at the county or state level or receive block grant funding. But starting in 2001, peers in Georgia and Arizona were among the first to start getting Medicaid reimbursed services for peer supports that were being provided. Center for Medicaid and Medicare Services offered guidance in 2007 on the requirements for getting Medicaid reimbursed services for peer support. And this really has set off a an exciting enhancement of the peer support workforce in mental health that's been quite amazing. 49 states, one of those CMS requirements is that individuals who get reimbursed for providing peer support services must receive some type of specialized training. And currently 49 states plus Washington, D.C. have such programs, and 47 states actually allow reimbursement through Medicaid for peer support services. So it's been a really exciting development. Some of the work that I've been able to do is to try to understand over the years what is happening in terms of the delivery of peer support. In 2008, 2009, I did a national survey. At that time, peer support was still growing. The workforce was still growing. I learned things like what are the average number of hours people are working, these kinds of things. One of the things that I was excited to learn is that people with lived experience who had this certification, they were certified peer specialists, were working in a lot of different types of settings. They were working in independent peer support programs. They were part of case management teams. They were working in psych rehab programs and partial hospital programs, inpatient crisis services, vocational rehabilitation services, drop-in centers. They were doing advocacy and education and working in residential programs and other types of settings. And they were doing a lot of different things, which is truly amazing. And I'm still impressed by all the things that I get to see around the country. But given this interest in peer support, I've also known that there are a lot of challenges and barriers. Some of those challengers are non-peer professionals and our perspectives about the value of peer support. I mentioned that I had the opportunity very early on in my career to really see that people with lived experience, certified peer specialists now, really have something to offer that non-peer professionals are not offering, and that type of help can be as beneficial as any other type of help or support that could be offered. But the concern is that my non-peer professional colleagues might not have the same understanding. As part of my master's study, this is a long, long time ago, I actually did some research where we asked more than 1,100 mental health professionals to rate how helpful are professionally led services delivered by a non-peer professional, support group services also led by a non-peer professional, and self-help mutual aid types of groups. How helpful were each of these? The good news is that these professionals who completed the surveys, they overwhelmingly rated self-help groups as helpful. So at least they said they were helpful, not unhelpful. But some of the challenges, and they also were willing to refer people to self-help mutual aid groups, and that was incredibly important. But one of the things that I also discovered is that they routinely, it didn't matter what the person's discipline was or where they worked, all the mental health professionals, the non-peer professionals, ranked professionally delivered services as more helpful all the time than self-help mutual aid groups. And this is despite the lack of research really documenting that professionally or non-peer professionally delivered services are more beneficial or effective than peer-delivered services. I referred to this distinction, the distinction between how helpful professionally led services are compared to peer-delivered services. The degree of that difference I referred to as professional centrism. The idea here is that it appears that mental health professionals view services that are delivered by mental health view services that are delivered by professionals as being more helpful than services delivered by peer professionals, and that the degree of this difference really had an impact on the intentions of those professionals to refer people to these kinds of services, to help organize these services, and to fund these services. We've also done research over the years, or some colleagues have done research really documenting that peer specialists in the workforce are experiencing some negative interactions with their non-peer professional colleagues that are really quite problematic. This is one particular study that looked at what are called microaggressions. These are everyday interactions that really intentionally or unintentionally convey disparaging messages to another group of people. And there's evidence that non-peer professionals are making jokes about their peer professional colleagues. They're questioning competence. They're ignoring coworkers or viewing them as lesser than non-peer professional workers. So we have a lot of concerns about this as a barrier to the effective implementation of this new and exciting workforce in mental health services. Some other issues that I've identified over the years that I have a lot of concerns about is some peer support programs are really poorly described and lack a program theory. In general, what I see is people say, oh, we provide peer support, and it's not really clear what else they're doing, what other activities they're doing. The goals are sometimes vague. This is not necessarily unique to peer support programs. This is something I often see to the same degree in non-peer programs, but this is something that does undermine the effectiveness of peer support services. The role for the peer support specialist is also sometimes poorly defined. There's role conflict and confusion. One of the things that I'm particularly concerned about is certified peer specialists being asked to do the same things that non-peer professionals are asked to do, deliver medications, talk to people about medication adherence, talking about symptoms and diagnoses, when this might not be appropriate from a peer support ethos. There's also lack of clarity oftentimes around self-disclosure. It's not clear whether people, peers, are fully aware that they're expected to disclose, don't always know when to disclose. And there is concern that some people have mentioned about being more vulnerable, especially with their non-peer colleagues, because they've disclosed something quite personal, sometimes publicly, and they feel that this puts them in a vulnerable position compared to their non-peer professional colleagues. Some other concerns are the preparations of the settings where peer support is occurring, agency settings in particular, and how the understanding of peer support services and the value of those services. There are concerns about human resources and how well they understand the value of experiential knowledge that is part of the effectiveness of peer support, and whether that experiential knowledge, that 20 years of knowledge about living with a mental health issue, should that be valued in terms of salary to the same degree as book knowledge or degrees, a master's degree, doctoral degree, something like that. And there's been a lot of conversations about people who have criminal justice involvement, and and that might be actually an important part of the position or experience that we're hiring for in peer support programs, but human resources might be rejecting those candidates because of their criminal justice involvement. There are concerns about supervision, how well non-peer professionals are really trained to supervise their peer support colleagues. And there have been some concerns expressed by professionals, non-peer professionals, about the ability of, without any evidence, that peer support staff can actually maintain confidentiality and adequately deal with whatever dual relationships might occur. So I'm not going to be able to go through all of these in a lot of details because I want to make sure I give enough time to my buddy Jake Bowling to talk. But there are a lot of things that we need to do. We need to make sure that non-peer professionals who are involved in developing these programs really are knowledgeable about peer support and what is peer support all about, the value of experiential knowledge, the value of knowledgeable about the theories underlying peer support, knowing that peer support and peer support programs, it's more than just hanging around with one another. We need to make sure that we're paying attention to policies like human resource policies, procedures, and other types of issues that might overrule some of the efforts of peer support programs. They might actually counter what some of the peer support programs are trying to do. It's critically to develop, to ensure that people with lived experience are involved in the development of peer support programs rather than it being non-peers who are developing these kinds of things. Supervision from peers as well is critically important. And the last thing that I want to mention that is in many ways kind of consistent with what Roy and Melissa were talking about is career development is also critically important. Really paying attention to the professionalization of this incredibly important and valuable workforce, making sure that they're valued, that we're supporting the development of people, including development of job skills and career ladders, and of income, maybe salary, maybe more importantly. So I am going to end there, and I'm open to any questions or comments if we have time.
Thank you so much, Mark. I really appreciate both your depth and breadth of knowledge and information that you brought this afternoon. I am seeing some great questions in the chat for you, but because we're short on time, I'm going to suggest that those folks either reach out to you if they have something that they think would be really transformational to learn, or if you have capacity and ability to chat with them in the chat, please do so. Okay, thank you very much. I appreciate it. And I'm going to turn things over to Jake Bowling. Let me get to my notes. There we are. So Jake Bowling is the Chief Executive Officer from Bowling Business Strategies, and he holds a master's in social work from Temple University. Go Owls, by the way. And Jake works to ensure that behavioral health services are engaging, accessible, consumer-driven, evidence-based, viewed as vital and routine to health, and completely free of all forms of discrimination towards persons with substance use and mental health issues. So go ahead, Jake, take it away.
Thank you, Alicia, and good afternoon, everyone. As Alicia said, I'm Jake Bowling. I work for Bowling Business Strategies. We're a consultancy focused on behavioral health services based in Philadelphia. And I started my career at a Mental Health America affiliate in Philadelphia, where I met Dr. Salzer, Alicia, Debbie Plotnick. So it's really a joy to be here with you all today to share some information around new reimbursement options for peers. So the first kind of bit of information I wanted to share with you, and I would ask if Alicia can drop the link in the chat box. My company was able to work with the National Council for Mental Wellbeing to create a billing tool for community-based providers in the mental health and addiction space. And it's called the Financing the Future of Integrated Care tool, which I'll talk about kind of the intentional naming in a moment. But essentially, it's an Excel-based tool that provides information on billing, staffing, and service opportunities for behavioral health providers. And so in the tool, it enables providers to access Medicare and Medicaid codes that are available within their states, along with revenue estimates based on billing codes. It allows you to look at the different staffing types that can bill for particular codes within your state. And it also offers case studies where you could actually project revenues based on billing reimbursement rates within your state. What the tool is unable to do, and I'll show you the tool in a moment, is it can't fully account for all of your state-specific billing environments, since Medicaid agencies and managed care organizations may have different billing rates for the same service across states. And it's also unable to account for value-based payment arrangements or alternative payment models that aren't based on reimbursement rates. So when you look at the tool, you see that it has a few components. It includes a descriptor of the services that can be billed, the specific billing code, so that's usually called a CPT code or a HCPCS code tied to that particular service. It provides a reimbursement rate of what Medicaid or Medicare would pay for that code. And you're able to sort by state to identify the state-specific billing code estimates. It will tell you the professional discipline exclusions, so which types of professionals can bill for which codes. And that includes peer support workers. They're included as one of the professional disciplines. It will give you insights into whether perhaps a third party or commercial payer would cover the service. It provides rate minimums and maximums and averages. It also provides guidance on documentation requirements, time requirements, and other special considerations. So if you see and sorry, this is a very busy and overwhelming slide, but it's a snapshot of what the tool looks like. And you could see that you can filter by general category of service. You see on the top that you could select the state that you're interested in. You see that you can look at payment rates, filter by staff types, and overall there are 108 codes included in the tool. And right now the codes are up to 2024. We need to make a 2025 update, which will be coming soon. I also mentioned that there is a functionality within the tool to do some revenue estimates. And one of the areas where you could do revenue estimates is if you deliver medications for opioid use disorder. And you could actually insert the anticipated number of clients that you serve, anticipated no-show rates, and then the types of services that are associated with your MOUD program, and it will generate revenue estimates for your program. I wanted to just hone in, though, on some new Medicare codes that are especially relevant to peer services. I think what I've appreciated about the presentations up to this point, as well as the people on this call, is we're all trying to advance the voice of people with lived experience in the behavioral health space. And I know that there are some programs that are more or less comfortable with billing Medicaid for those services. And that certainly is up for debate, and it comes with pros and cons. But I also wanted to just avail you of the Medicare options that are available for peer support that are new. Two of them came out in 2024, and two of them are coming out in 2025. And those are principal illness navigation, and forgive the lack of strengths-based language here, but this is how it's referenced in the Medicare fee schedule. So principal illness navigation and patient navigational services and peer recovery services. And I'll kind of jump into each one of those opportunities. But first, before we talk about that, I wanted to kind of pull the thread of why we're talking about Medicare in the first place. I would assume that many of you are used to working with perhaps your state behavioral health authorities, block grant funding, SAMHSA funding, or Medicaid funding that comes through a managed care organization or directly from your state. But the reason Medicare should be part of the discussion is because when Medicare releases new services and codes, generally state Medicaid agencies use Medicare as a guide for what they're going to cover in their state Medicaid plan. They also use Medicare pricing for reimbursement rates to guide how they cost out the reimbursement rates in Medicaid. So it's important to be aware of what Medicare is electing to cover because you could then push your state Medicaid agency to cover similar codes. Commercial insurers also use Medicare as a guide for the codes that they cover. Medicare tends to pay better than Medicaid. And also, as of last year, Medicaid now allows for a place of service of outreach site or street, which means that you can deliver Medicare services in settings like outreach teams and receive reimbursement for those services. So that's especially important for individuals experiencing homelessness that we serve. And codes are currently available for providers now that serve Medicare beneficiaries and settings that are non-specialty behavioral health settings. So essentially, if your setting is an outpatient medical practice, for example, they would be able to access these codes for individuals who are on Medicare. But again, for those who aren't on Medicare, for those who are on Medicaid, the idea is that these codes could be opened and priced for individuals with Medicaid and providers that that request Medicaid reimbursement. So a quick dive into principal illness navigation, which is one of the opportunities that I mentioned. These are services that are designed for individuals with serious conditions that are expected to last at least 3 months. And mental health and addiction challenges are included on that list of serious conditions, along with other types of healthcare conditions like HIV/AIDS, cancer, COPD, congestive heart failure. This service is really designed to help address social drivers of health and can be especially helpful for members of disadvantaged communities who often receive lower rates of patient navigation and are diagnosed with these types of conditions. These services are also designed to fill a critical gap in navigation services. So we know that our system and services can be really challenging to navigate, but there aren't a lot of billable opportunities to assist with the navigation. Those opportunities are often grant funded, and this is meant to close the gap. So a bit about principal illness navigation. It involves a person-centered assessment, delivering kind of patient and caregiver supports, providing health education to help the individual have more insight about their condition and how to manage their condition, the building of self-advocacy skills. Also, it involves facilitating behavioral change, helping the individual navigate the health system, providing a social and emotional support, and leveraging knowledge of the condition to help the individual meet their goals. So as you can tell, even though the language is kind of medical model language, the scope of service is very aligned with what a peer supporter would do. And there's one code that allows a peer supporter to provide 60 minutes per month of service. And then there's an additional code to provide additional 30-minute units throughout that month. And there's no frequency limitation on the additional 30-minute unit. So with principal illness navigation, it does have to occur under a qualified practitioner, and Medicaid has definitions for who those qualified practitioners are. Certified peer specialists, the reason that they're able to deliver this service is that they are considered what's called auxiliary personnel, along with other professional types who are trained to provide the service. They are under the supervision of the qualified practitioner. So while that practitioner, like a physician, for example, does have oversight, they don't need to be present for the service to be delivered. And actually, a qualified practitioner can contract with a community-based organization or a peer support organization to deliver the service and still be able to bill under the qualified practitioner. So I won't get too in the weeds around this workflow, but it essentially kind of reinforces what an initiating visit is, what the types of codes are that count as an initiating visit, and what the subsequent PIN visits can look like. So I know I also mentioned a couple other codes that are coming in 2025. So when you have the slides, you can like look at those codes and determine whether those are a good fit or whether there may be opportunities to open up those codes within your localities. But I think the major takeaways here are first, familiarize yourself with the new Medicare services that are related to peer services. And then I would say assess opportunities for optimizing these codes within your communities. So are there opportunities with providers that are delivering services to Medicare beneficiaries where peer services could be added on and reimbursed for? And can you take those services and codes and advocate with your Medicaid agency to open them up for individuals on Medicaid and commercial payers? Consider your role in directly delivering these services or partnering with other entities to deliver these services. And I think this was a message in both presentations. Ensure, given that these peer services are often embedded in non-specialty settings, ensure that any peers delivering these services have the support structures necessary to be able to both work under the direction of these qualified providers, but also still retain, the importance and the scope of practice under peer support. So with that, I will just display my contact information and turn it back over to you, Alicia.
Jake, thank you so much for your expertise. I really appreciate that you shared a concrete tool for us, which I did drop into the chat, and then also some thoughts about how Medicare coding could hopefully become Medicaid coding accessible. That's pretty exciting. So folks, we are at time. So I just want to say thank you so much for attending. And I also want to thank our speakers and to Jackie Zimmerman here at Mental Health America, who helped coordinate today's webinar and make things run smoothly. The work of the Regional Policy Council is made possible by funding from Bristol Myers Squibb, Compass, Johnson & Johnson, Pfizer, Myriad Genetics, Neurocrine Biosciences, Otsuka, Sage Therapeutics, Biogen, Takeda, Lundbeck, and Teva. We couldn't do it without them. In a follow-up email, we're going to share the PowerPoints and speaker contact information as permitted, along with the links that we shared and a recording of the presentation. So you should see that maybe by Monday or Tuesday. It takes a little time to process that recording. So thank you so much for being here, and I look forward to seeing you next time. Have a great one.